Good morning or afternoon, depending on where you are. My name is Sarah Jemison, and I would like to welcome you to our webinar series presented by Cherene Allen-Caraco. This presentation will last about an hour. We will have time for questions at the end. There is some options on the right-hand side of your screen where you can pose questions or use the chat box. I will be fielding those for Cherene, but we would very much like to welcome Cherene and her expertise in recovery.
Thank you so much. So I am so excited that you all decided to spend your lunch with us today talking about what is absolutely one of my favorite topics, and that is recovery from mental health, substance use, and co-occurring disorders. One of the reasons why I like it is it's just so hopeful and positive, and it really can alter the trajectory of somebody's life. And so we are doing a several-part series just on recovery, and today we're just going to be talking about the basics and giving some foundational elements. Now, I do want to tell you that I do about 68 hours of training just on recovery, so you're getting about a 45-minute snapshot. I did include a lot of extra information that we won't be able to cover today, but I wanted to make sure that you have it available to you to look through and look at some of the resources and information. So just a little bit of context, if I can get my computer to move here. A little bit of context about me. I am a consultant for CQL, and I have been working for CQL for about 4 years. My focus is on behavioral health system transformation and also working with states and systems to become co-occurring competent, supporting people that have co-occurring intellectual, developmental, and other disabilities, as well as mental health and substance use issues. So I work on several special projects within CQL. I'm also a person in recovery. I've been in recovery for 27 years, having first diagnosed with a mental health issue when I was 13, and subsequently receiving many additional diagnoses. And I talk about it very openly, and part of the reason why is for so many years I hid and didn't share it, and there's a lot of shame and quietness that goes along with having diagnosis of mental health issues. And I made a decision at some point when I was able to move forward in my life and push my own recovery forward, that if I ever had a platform, that I was going to talk about mental health issues and what that experience feels like. And so I do that with almost every presentation that I have. I just am very open about it. I'm also the CEO of an organization called Promise Resource Network, and if you have questions, you want to look up the organization, where I have our websites. We have 2 websites that are up, and my email is at the end, so please feel free to email me if you have specific questions or want additional information. Just to give you a little bit of information about Promise Resource Network, I started the organization in 2005 in development. In 2006, we launched. And it really was in response to a behavioral health system that is not designed to support people like me to move forward and find wellness and health and thrive despite having mental health challenges. And so we were designed to advance knowledge and skills related to recovery-based practices, system transformation, health and wellness. And so we do a lot of work around system change. We operate several programs. 3 of them are technical assistance centers. So Recovery University does a lot of training for providers and managed care organizations and government officials, as well as people with mental health and substance use diagnoses and family members, just about recovery and what helps and what hinders the recovery process for people. Our second one is Peer Academy. We do a lot of training for peer support specialists and non-peer supervisors around the country to advance peer support as a professional discipline. There are some skills and some values and philosophies and approaches that make peer support very effective and demonstrate some exemplary outcomes, but we want to make sure that people are able to do it well and have the tools to understand how to integrate it into their agencies or how to provide peer support well. And then the last one is work for recovery, and that is all about competitive employment. We do a lot of work around employment. I'm going to touch on it a little bit today, but we have a web lunch and learn that's just devoted to talking about employment and education of people with diagnostic labels of mental health, substance use issues, and co-occurring challenges. We also, in Charlotte, North Carolina, operate a variety of resources that really are based on quality of life and supporting people to understand their own mental health and find their voice, really, and take back their life. And so you're going to see a lot of different resources that are operated by us. We work with a lot of people who experience homelessness, have been incarcerated, have been in the hospital system, in treatment programs. And of our 30 employees, probably 28 are also in recovery with very similar backgrounds of the people who walk through our doors looking for support. So in that way, we are what's considered a consumer-operated services program, or you'll hear it called a peer-operated program. There is a great deal of attention being paid to the concept of recovery, and it really is being used to change our landscape of mental health and substance use services, and the way they're funded, the way they're viewed, and the practices that are used within those systems. It's a subject of research and national reform efforts and measurement tools and training, program development. And so there's a lot of buzz around recovery, which is not new. It's been happening for quite a while, which I'll share with you a little bit of it. Part of what the impetus is for recovery system transformation is the Department of Justice settlements and Department of Justice lawsuits that we're seeing emerge throughout the country. I live in the state of North Carolina. We actually are under a settlement right now. There are numerous states that either have been sued or under settlements with Department of Justice, and it all centers around the Olmstead Act and the idea that people with mental health issues really have been segregated and institutionalized for many years, diminishing quality of life and decreasing opportunities for people to recover and be well. And so in addition to our intellectual and developmental disability system having Department of Justice settlements on the behavioral health side, that is also occurring around the country. As a result, it's really pushing for a fundamental shift of the way services are delivered and the system is designed. Amongst our own in North Carolina settlement, this is actually written from the settlement, so I took it right out of there, that services and supports for people with mental health challenges must be evidence-based, they must be community-based, they must be oriented towards recovery and wellness, they have to be flexible and individualized, they have to help people increase their ability to deal with situations that may otherwise result in crisis situations, and increase and strengthen the person's community, connection, as well as their use of support for prevention and intervention. And it is, I spared you, that's one slide of about 120 pages of a settlement with a lot of legalese, but these are some of the primary thoughts around the settlement in North Carolina. Now, this isn't new, so now that we have all these settlements happening around the country, it actually builds on work that's been done in the beginning of the 1990s in the country. In 2001, President Bush actually summoned a report called the New Freedom Commission Report, and what they wanted to do was to analyze our federal system, behavioral health system, and see how effective or ineffective it is, and then make recommendations. They went to all 50 states, they talked with 2,500 people, and they had a final report called Achieving the Promise, Transforming Mental Health Care in America. And I know this is not a surprise for anybody that's on the phone, but what they determined was that our system is very fragmented, that we have inadequate resources, and the efforts towards recovery are thwarted, but that recovery is absolutely real, and it's not only possible, but it's probable. But our system is not oriented toward wellness and recovery. One of the key findings that still appalls me when I think about this and I see this is that treatments that are based on research are not in the hands of our provider community for about 15 to 20 years. So I think about what's happening right now in the field, and there are practices that have emerged that have demonstrated effectiveness that we are not going to have in our hands for another 15 to 20 years. And there are others that we're just learning about that have been around in research for that period of time, but we haven't had access to them as people who support folks in recovery. That's appalling. And so there's a lot of effort being done to accelerate from research to practice and to create an urgency around system transformation. One of those initiatives is from SAMHSA, the Substance Abuse Mental Health Services Administration, and they have an initiative called Recovery to Practice. They're focusing on 5 key practitioner-level training. That is psychiatry, psychology, psychiatric nurses, social workers, and peer specialists. And the goal is to really advance the knowledge of recovery, recovery-based practices, approaches, and models so that people can start applying these within their work that they're doing. Another goal is to transform our mental health system to one that expects recovery rather than recovery being the exception, and then to have all of the disciplines work together and then accelerate some of the research around recovery. They have a variety of different things that they do to support this, including a recovery resource center. If you Google Recovery to Practice SAMHSA, you will find a lot of materials and webinars and trainings just on recovery and system transformation. And then they do a lot of dissemination of that training through face-to-face and online training opportunities. So I throw that out to you just so you know that there are resources available, and this is something that is really garnering wide attention. We're going to start to see, if you haven't already, a push to change the way we view people with mental health and substance use issues and how we're providing supports to them. So among the changes, just to give you a little bit of context, our system has really been designed around a medical model, and it's been that way for many years. Partly it's because we did the best with what we knew at the time, and so we designed the system around monitoring illness, monitoring symptoms, having low expectations. So things like you shouldn't go back to school because it's too stressful, or work is too difficult. Your job is really to focus on your treatment. The focus is on problems and symptoms and maladaptive behaviors and all of those type of things, where the control really lies within the service provider. There's a lot of social isolation, lack of involvement of the person themselves, a very strong emphasis on medication and medication compliance. And the result of it is that your life is built around services. Providers have a lot of the power, and people end up feeling helpless and hopeless, and it's also expensive. So if we were to map it out in a medical or maintenance model, you look at somebody and where they're at what's called baseline, so their regular, everyday, how they're operating, and then they decompensate, and the goal is to get back to baseline. In order to do that, we focus on symptom reduction and medication, being stable, not really risking a lot, and having low stress. And the goal is really around stabilization and maintenance in this type of system. So we want you to be protected. We want you to not push yourself too much because it's too stressful, and you'll decompensate. A recovery model is almost just about the opposite of that. It really is about looking at quality of life and supporting people to have the life that they want. There's a lot of wellness self-management, which if we have time, we'll talk about at the end. A lot of partnership type of approach, so that hierarchy of I am the clinician or I am the psychiatrist and you are the client is minimized. It's pretty much erased in a recovery-based approach. There is a focus on development of skills rather than on treatment, and of learning through doing. The person is empowered. It demonstrates impact in terms of effectiveness. There's a decrease of a reliance on systems and ongoing treatment, and so of course it's less expensive. The trajectory of the recovery approach, it shifts. It says that people will have an upward trajectory over time. That means that people will recover over time, and that there are times where we plateau, and then there's some distress that happens in our life, and that's an opportunity to learn and then grow, and your plateau increases. So your resilience and your recovery increases. And then there's distress and learning, but ultimately you're going forward and you're moving upward. In order to do that, our focus is really on the person rather than on the symptoms and treatment and diagnoses and medications. So we talk a lot about whole health and 8 dimensions of wellness, and I'll share with you in a little bit what that is. So in order to start thinking about recovery a little bit differently, I do want to talk about what it's like to live with the impact of emotional distress and psychiatric labels. I will tell you that one of the things that research has yielded is that the impact that somebody experiences is really not about the diagnosis or the symptoms. It's about the way they are viewed and the way they are treated that people are recovering from. People can live with mental health diagnoses. What's difficult is when you are viewed as incapable and your opportunities to live your life are diminished. You can really start believing that and go into this place of hopelessness and helplessness. So there is a whole identity, and I'm sure some of you know people who are caught in this identity of patient. A patienthood identity is all about my diagnosis and my treatment. My life revolves around services and around groups and taking medication. You may know people who've been sitting in a day treatment program in the same seat for 30, 40, 50 years. I know that I do. That tells me that that is a person who is stuck in that patienthood identity. And that means that they're not able to have other identities. What is it like to be a homeowner, a mother, a son, a daughter, a student, an employee, all of those other things that we are as human beings? When you are nothing but a patient, that means that you are a passive recipient of services. And along with that patient identity comes some stigma and some self-stigma. So stigma, we know, is something that's judged by others as a mark of disgrace or shame. Self-stigma is when we view ourselves through that lens. So when we feel incapable, when we become over-reliant on others, when we say, I don't know what I want to do, what do you think I should do? Or I don't have any goals, you tell me the goals I should have. We know that people can be stuck in that cycle of hopelessness and self-stigma and patienthood. We see this playing out in people's behavior all the time. I often say, we hear a lot in behavioral health, this person is non-compliant, or they're service resistant, or they're difficult, all of these labels. And I want somebody to still have enough of a voice that they are going to question and they are going to stand up and try to figure out how to have a life. That's not a negative thing. That's a positive thing. What scares me is the people that walk through life and they're taking up space, but they seem to have lost their soul, and they've lost their spark, and they've lost their zest for life. That's really concerning. That may tell us that that person is really stuck in this dark place of helplessness, seeing themselves as a patient and nothing else. To be a patient is a lot of shame. It's a lot of fear. It's a lot of distrust of who you are. It's unwilling to take risks. It's lack of knowledge and information being withheld from you. It's also about stagnancy. I do the same thing today that I'm doing tomorrow, and it's the same thing that I did yesterday. Who wants to get up for that? And so there can be a lack of meaning and purpose that goes along with being a patient. You live from appointment to appointment, group to group, meeting to meeting, and service to service. We know, just generally, as human beings, we wonder who we are. What are our beliefs and our values, and what makes us tick? What are important things to us? When you have a mental health or substance use diagnosis, it can be even more challenging to figure out your real identity. When you're a kid, you're asked things like, what do you want to do when you grow up? and what do you want to be, and what do you want to get married, do you not want to get married, do you want a career, do you want to go to school? Well, when you have a diagnosis, those questions are often replaced with questions such as, what are your symptoms today? How is your Haldol injection going? What are the problems that you're having? How are your voices? And they're replaced by words like schizophrenia and bipolar disorder and treatment language. So no longer are we asking people who they are. We're talking about their symptoms and their diagnosis. And that really can trap us into feeling sick and broken and ill. The culture of patienthood is a culture of overuse of medications, and I see this in my peers all the time, looking for a magic pill. Just give me the pill that's going to make it go away, or give me the treatment that is going to work. And then I get frustrated and angry and upset when I go to this therapist and they're not making it better. It's a focus on deficits and everything that is wrong with me. It's a lack of voice and ownership. It's being viewed as being incapable and viewing myself as incapable, and it's being subjected to things like coercive treatment. If you don't follow the rules, you're going to be kicked out of this program. Or forced treatment. If you do not take your medications, you're going to be involuntarily committed. These are the things that you experience as somebody who's been diagnosed on a regular basis. This is came from 1984, Ray Zuniger, and it's just a little quote about what it's like to be a mental patient. To be a mental patient is to be stigmatized, ostracized, socialized, patronized, and psychiatrized. To be a mental patient is not to matter. It's to wear a label that never goes away, and a label that says very little about what you are, and even less about who you are. To be a mental patient is to act glad when you're sad and calm when you're mad. And to be a mental patient is to participate in stupid groups that call themselves therapy. Music isn't music, it's therapy. Volleyball isn't a sport, it's therapy. Sewing is therapy, washing dishes is therapy. So I just thought this was a nice illustration of what it feels like to be in that patient role. I borrowed this from our colleagues at Recovery Innovations. It's called the D list, and it's a really good illustration of what happens when people enter our system. So I come into the system, and I'm having difficulties and disappointment, whatever that is. It might be life stressors. It might be what would be classified as symptoms of distress. A lot of people are coming in with very specific trauma experiences. As a matter of fact, over 90% of the people we see in our system have experienced trauma. And so we come in with these difficulties, and we're experiencing distress. And we're coming in looking for some help around that distress. And then you end up with a diagnosis, or in my case, with 6 diagnoses and 2 pending. Diagnoses are really interesting because you never get rid of them. You just sort of add on throughout the years. So then you're a walking DSM manual like I am. So you get these diagnoses, and you also oftentimes get this prophecy of doom. I was told, for example, I was always going to be in the hospital. I was had to have low expectations around work and career. I graduated from Syracuse University. Thank you very much. But these are the things that you're often told when you're given a diagnosis because you have a disease. You have something called mental illness or substance use issues, and that is a disease that never goes away. And that disease is in your brain, and you're always going to have it, and it's never going to get better. And then you're classified disabled. One of our biggest challenges is less than 1% of people that go on disability benefits ever get off. And to be on disability benefits means that you live a life below the poverty level. And we know that poverty is related to chronic illness, chronic physical illness, chronic emotional illness. And so we are pushing people to see themselves as disabled and get on benefits and sit at home and do absolutely nothing with their lives and wonder why they're constantly in and out of hospitals and in and out of jails. When you are viewed as disabled, you easily see yourself as disabled, and then you get into that world of helplessness and hopelessness. When you're disabled, you become disempowered because what you're taught is that you can't trust your own mind and you can't trust your own ideas and your own judgment. And so you sort of give it up to the world and say, well, I don't know what I should do. You tell me what you should do. You're my doctor. you're my case manager, you're my therapist, and our voice slowly starts to go away, and then you become disenfranchised. Because when you live in poverty, you do not have power. You live on benefits, you live on subsidies, and when those subsidies go away, you end up in the streets. And so you become very disenfranchised and seen as a person that's sort of an outlier in the community without a lot to contribute. But you have a lot to receive because you're a service recipient. You just don't have a lot to offer. And that experience can be really demoralizing, and you walk into this world of dysfunction. And before you know it, the person is completely covered by all of these Ds. The person is lost. Who they once were and who they are as a human being gets lost in all of these Ds. The messages that we can provide are really soul-crushing to people, and they're identity-shattering. So we have a lot of work to do to reshape the view of what it's like to have a mental health or substance use diagnosis. So enough of that. Let's talk a little bit about where this comes from. And there are so many different reasons why our system has gone in this direction. One of them is called the Clinicians Illusions. For the clinicians that are on the phone, I'm sure that you've studied this in college, but the Clinicians Illusion in a nutshell basically says, because this is what you do every day, you work in illness. You work with people who come in, they're experiencing acute issues, and you see people who are ill all around you. What you don't often see is what we are like when we get well. And so, unfortunately, you're surrounded by a lot of unwellness every day, and you can come to believe that that is what mental health issues is, that people actually don't get better. One of the things that we can do as people in recovery is be open about it, talk about it, and talk to the provider community about things that they're doing that are really helpful, that have helped us to move on, about recovery and what it looks like, and things that they are doing that aren't exactly working very well. So we need to really reshape this vision of what it's like to be in recovery and introduce that world to our clinicians who are working with people who are unwell every single day. So I've been in recovery for 27 years. I have not once gone back to my treatment provider and said, oh, by the way, I'm a national consultant, I'm a CEO, I have an organization that is several $1 million, and I appreciate everything that you did for me. They have no idea necessarily who I am or what I've done with my life. The last time they saw me, I couldn't stand up, and I couldn't get up in the morning, and people had to carry me to the bathroom. So they haven't seen what my life looks like today, and that's really unfortunate. We need to start sharing messages of recovery. Some of the other things that are contributing to this is our attitudes and knowledge about recovery research and outcomes is still very, very limited. We still have a system that believes that the most people can hope for is to be stable and to maintain and manage their symptoms. So this idea of actually thriving is not in the hands of a lot of the provider community that needs to understand what helps people recover. We still have a system that is not necessarily innovative. We're stuck in that place. We're looking for solutions around things that we already have instead of looking for things that we don't have currently but that could actually work. There still is a lot of paternalism and low expectations. I still hear a lot of, you can't work, you're not able to work. Employment will keep you sick, it's too stressful. So we are still pushing people into that dependency role and that client role. Our system is designed around stabilization and maintenance and on quality. We bill in the behavioral health system typically around units, 15-minute face-to-face contacts. We're not billing necessarily around quality, so the outcomes and the impact of the work that we're doing. And so while we continue to focus on quantity, we will continue to focus on seeing people instead of helping them be well and get better. A lot of traditional treatments and approaches that have not been designed around health and wellness. They've been designed around stabilization. This is one of the things within my peer community that frustrates me, is when there is a voice to be had, we go to the state, we go to the federal government, we talk about adding more services, And one of the things that we should be talking about is improving the services that we have to re-gear them towards things that are actually helpful, paying for best practices, paying for recovery and rehab, not treatment and taking care of people. And then one of the biggest disappointments is valuing the lived experience. I do not regularly see people in recovery that are at high levels within an organization or within a system that is helping to shape the way services are delivered. That is a huge disadvantage because there is nobody better that understands what works and what doesn't than somebody who utilizes our services. And so we need to start propelling people in recovery to positions of transformation, hearing their voice, valuing their voice, and having them shape the way the system is designed. So what is recovery? I get this question a lot, as you can imagine. And this is the Webster's definition. It's to regain or to restore to a normal state. I can tell you in talking with the thousands and thousands of people around the country who live in recovery, this is not really the way it's defined. And mostly it's because people say, I don't want to get back to where I was. Where I was is what led me down this path. I don't want to go backwards. Recovery is actually about going forward. It's not about going backwards. And so what is recovery? Here's some personal definitions. If I offend you, by the way, I apologize right off the bat. This isn't my definition, but it's a definition that needs to be heard and needs to be valued. This is the definition of one of the people that I work with, and I asked her to define recovery. And she said, it's letting go of old ideas and embracing new ones. Rather than a should have, could have, fear-based mentality, I accept me in all my glorious strengths. I was created exactly the way I was meant to be. Kiss my ass, you demon from the past. And I just loved it. That's what we're talking about when we're defining recovery. The one below is understanding who I am and where I've been and how I got there and how to forget and forgive to move forward. It's about survival, no matter what anyone says about me or tries to do to pull me down. So you're going to see a common thread in recovery definitions that it's about moving forward. It's not about staying stuck in maintenance. It's not about functioning. I have a colleague that says, functioning is what I do in the middle of the night when I go to the bathroom. I don't want to function. I want to live. And those are two very different things. Recovery is defined by the person, and one of the things that you can do if you're not doing it already is start introducing people to the concept of recovery and introducing them to national trailblazers, people that have recovered and they talk about how they recovered. Introduce people maybe for the first time that there is hope that goes along with having a diagnosis, and then ask them to define what it looks like for them. That is a beautiful place to develop a plan around. My definition of my recovery is the starting of a good person-directed plan. It's often referred to as a process or a journey that includes self-awareness, building my identity and my self-esteem beyond that of being a client. There is no magic. I tell you, I wish somebody had told me when I was first diagnosed that it was not going to come in a magic pill or a treatment, that if you want to be well, you have to step up and suit up and show up, because it is a lot of hard work. Nobody ever said that to me. And so I make a point of telling people, you can have the life that you want. You're going to be working your butt off. It's having or getting a life, the one that you want, not the one that others want for you. And it may include recovering what you've lost, your dignity, your responsibilities, your purpose, your meaning, your rights. This is a big one. It's about rekindling hope and being able to dream. Who am I and where do I want to be? If yesterday looks like today and today looks like tomorrow, what is the point of even getting up? If I've been 30 years in the same day treatment program doing the same thing, what is the point? We want people to find their hope and their purpose again. It's also about overcoming and healing and transforming. Healing from the trauma that may have resulted in this experience of mental health diagnoses, healing from the way that you view yourself, the way others have viewed you, and some of the treatments that may have been really well-intentioned but actually did more harm than they did healing. And so to recover is to heal from so many different things. And recovery is not only possible, it's actually probable. And I'll give you some of the research, the national research on recovery rates in a minute. Recovery is no longer viewing oneself primarily as a mental patient. It's reclaiming a positive sense of self. So that's it in a nutshell when we talk about recovery. What's a little bit trickier is how do you actually foster this within a service delivery system. There is a national definition of recovery, which is at the bottom. This actually came from SAMHSA, and it's very similar. It's about a journey of healing and transformation. It enables people to live a meaningful life in the community that he or she chooses while striving to achieve his or her full potential. So that is our official definition of mental health recovery. A couple things about what recovery is not. It's not stabilization, functioning, or maintenance. As a matter of fact, most of the people that I know, if I ask them if they would like this thing called mental illness removed, if I gave them a pill and it got rid of it, would you want it? Most people say no. And I would say no. As much as I've been through in my life, I wouldn't want it removed. And part of the reason why is the enormous gift that I have been given as a result of experiencing childhood sexual trauma, moving on and having these diagnoses, feeling helpless, but then overcoming all of that. I've been given amazing gifts, including a career that I absolutely love. I would never give it back. And so while we have a system that's designed around removing the symptoms or maintaining people, we have people that don't want that at all. They actually want to learn how to live with it, not to focus on it. Recovery is not an exception. It's actually the expectation. As much as we want to think that we're special, and I'll focus on myself, I'm actually the expectation around recovery. I am not unusual. I am a person that lives their life in recovery, that has many diagnoses and still is on psychotropic medications and in treatment and all of those things, but I'm not the exception. I'm actually the expectation. Recovery is absolutely not about compliance. Recovery is the opposite. It's about finding what works for you, having a voice, and directing your life. It's not about simply complying with what treatment providers want. It's not formulaic, and this is one of the things that's really difficult for the provider community, is I can't give a formula or a recipe that if you do this and you do that, people will recover, because it's so individual. I'm going to spend a lot of time talking about what worked, and we'll be doing that moving forward. So you're going to learn new tools and gather information, and you're going to have to try them out and see what works for the person that you're working with. It's not something anybody else can do for you. It's not your case manager's fault or responsibility. It's not your therapist, and you can't blame your psychiatrist. If you want to get better, you have to do the work. They offer the tools and the support. It's not about being nice. As a matter of fact, I know at CQL we call that the little R of respect. It's actually valuing people and seeing that they have something to offer the world. And it's not a cure or removal of symptoms. Where did it come from? I'll just go through this pretty quickly because I want to focus on some of the tools. There are thousands and thousands of examples of people who have shared their stories about how they've recovered, and sometimes how they've recovered despite the system and despite services. And so the recovery movement really emerged from people who live in recovery that started talking about it. It began in the 1980s with different stories that were emerging around recovery, and the reaction to forced treatment and lack of choice and focus on deficits and diagnoses. So people started talking about how that was harmful and how they actually recovered despite that prophecy of doom. In the 1990s, there was a writing called Recovery, the Lived Experience of Rehabilitation by Pat Deegan, who is now an international consultant about recovery. And she talks about her experience in psychiatric hospitals and how she was treated and what she was told and what it was like to be over-medicated. But while she was being over-medicated, what the system was saying about her is that she's getting better. What she was saying about herself is, I'm losing sight of who I am. My soul is being drugged out of me. And so she started writing her own experience. In the 1990s, it was called the Decade of Recovery. There was a commentary, Recovery from Mental Illness, the guiding vision of a mental health system. And so it's certainly something that has been read about and written about. So as people in recovery started talking, professionals and researchers started listening, and research around recovery and consumer-oriented supports started occurring. People in recovery started emerging as experts and going back to school, getting their doctorate degrees and their clinical degrees, and becoming therapists and psychiatrists. Consumers, people in recovery began being employed by systems and being involved in planning and policy making and evaluations and service provision. And so we started emerging in that way. Recovery research tells us that given the right combination of attitudes and supports, people can fully recover from mental illness. This comes from Dan Fisher, who is a well-known psychiatrist and medical doctor who was diagnosed with schizophrenia when he was in his late teens, early 20s, and hospitalized and told that he would never get better. And of course, he moved on, got better, got his doctorate degree, and he is now a national, international consultant around the recovery movement. So here's the myth, that only a few select people can recover. The number of times I have had people call me a high-functioning consumer, I think I would be rich by now if I had $1 for every time somebody called me a high-functioning consumer. I'll tell you part of the reason why that's insulting to me. It's insulting because it identifies that I am an exception and that most of the other people that experience what I experience, there's no hope for. And so the truth of the matter is that recovery research demonstrates that it is the expectation. It's not the exception. Recovery research began around 30 to 40 years ago, and one of the most significant studies that really kicked us off was a study out of Vermont. It was from Dr. Harding and some colleagues. It was a 32-year longitudinal study, and they studied what was considered the bottom 19% in their state hospital in Vermont. Most of the folks in the study had been hospitalized for over 10 years, and they followed them over 32 years. What they found is that 62 to 68% of people that they studied actually fully recovered or significantly improved. Now, here's a couple things that make this study unique. Number one, everybody that was in the study had a diagnosis of schizophrenia. The reason why she chose that diagnosis is because that is the one diagnosis that we have historically believed people can never get better from. And so they wanted to choose the people that really were so institutionalized, they started reverting back to animal-like behaviors and speaking in tongue. And, you know, these are people who are at the back ward of hospitals with a diagnosis of schizophrenia. So that's one of the things that made this unique. The other thing is that she used a very strict criteria of recovery that is not used today. But there are reasons why she chose this criteria. The first one was having a social life indistinguishable from your neighbor, so being connected to community completely makes sense. Having a job, either pay or volunteering. Being symptom-free, so having no current signs and symptoms of a mental illness. And being completely off of medication. Now, this isn't how we define recovery today, but she went to a very stringent version because she figured, okay, if these people actually get well, there are going to be a lot of backlash, like, oh, yeah, but they're still on medications, or yeah, but they're still experiencing symptoms. So she wanted to come up with the most strict definition that she possibly can. Out of these folks, what they found is that half of them, 34%, met 3 of the criteria. The other 34% met all 4. The 3 criteria that half of them met were the social life, working, and being symptom-free, but they stayed on medication. The other 34% met all 4 after 32 years. As you can imagine, it blew the lid off of what we thought about mental health issues. We now, these are a few of them, we now have 11 longitudinal studies in place that demonstrate the same recovery rates, that the majority of people with the most complex mental health issues actually recover, get better, and move on with their life. It dispels the notion that mental health issues are chronic, that they're constantly a deteriorating condition, and it concludes that recovery can either be supported or it can be deterred. So that's the good news, bad news of it. The good news is we can absolutely foster recovery. We can't recover for people, but we can have a significant impact in people's ability to move on and be well. The bad news is that we have the power to do absolutely the opposite. We can completely hinder recovery unintentionally by the messages that we give people, the way we view them, the way that we treat them, and the types of services that we provide to them. It's an awesome opportunity, and it's a pretty scary responsibility that we have. So what are the types of things that help and that hinder recovery? Well, there are a whole bunch of things. Some basic things. People want to be able to have meaning in their life. That's all people. So look for employment and education is huge. And we do a lot of training on looking for career opportunities. We're not talking about placing people into food service or factory work or cleaning of grounds. We're not talking about enclaves. We're not talking about work crews. We're not talking about sheltered work. We're talking about integrated competitive employment at a livable wage. That is what people are looking for. People want to love and be loved, and not by people who are paid to be there. To have value other than being a client, and to have valued roles in the world. Want to have safety and be respected and have their rights honored and have personal control. The forced treatment, coercion, and threats do not work. They actually do the opposite, and they re-traumatize people. People want choice and options. They want to be able to select the things that they know will help them be well. And of course, they want to have hope that they can have a home and have a car and do the things that everybody else wants to do. And of course, people want a home. We talk a lot about housing, and we find based on research that people aren't looking for housing. They're looking for a home. They want a place that they choose that they can live in. They're not looking for a slot or a placement, but a real home. So those are some basic things. Those should look familiar to you with your CQL, personal outcome measures, and quality of life indicators. It's what everybody wants. Some of the things that we've learned are actually helpful. Number one is having someone, one person, who truly believed in me and believed that I could recover made all of the difference. So it's when everybody else was talking about you or at you, it's the one person who is actually talking with you. It's having the opportunity to replace the role as a patient, a client, and consumer to being a student and a tenant and a colleague and a homeowner. And those are the things that change people's identity and their confidence and their view of their future. There are 4 dimensions of recovery and 8 dimensions of wellness. They're very similar to CQL's personal outcome measures. And it really is the things that help people recover are health, home, purpose, and community. And that if we focus on the whole person instead of the symptoms, we are going to support people to uncover their lives, their quality of life. This is the 8 dimensions of wellness just in a visual format. Obviously, it includes vocational and spiritual and financial, having emotional health, being intellectually challenged, having a home that I love that gives me a sense of well-being, and having social connections. So some of the things that you can do if you're not familiar with, there is a whole discipline around recovery called psychiatric rehabilitation. And psych rehab was actually designed to change from an illness-based system to helping people learn the skills to move forward in their lives. You'll see the S plus S equals S and S, which basically means that skills and support equals satisfaction. The concept of it, and I'm just going to go through these really quick. This is Dr. William Anthony. He was working within a system that would have people who are veterans, people with mental health issues, physical health issues come in. And he saw that when somebody came in with a traumatic brain injury or a physical health issue, they automatically were surrounded by rehabilitation. So occupational therapy and physical therapy and all of these different resources that are designed around health and wellness and building up your skills. But somebody with a mental health issue or a substance use issue would come in, and they would be given medications and handed treatment. There was nothing rehabilitative about it. And so he went on to design what's called Psychiatric Rehabilitation, which basically means that we can unlearn those negative messages, have opportunities and experience to build our skills and to acquire support to be able to have the life that we want. And so I won't go deep into this. Obviously, these are a whole series of trainings just on psychiatric rehabilitation, but if you're looking at tools, this is definitely one that I would recommend that you take a look at. And I'm just going to do a couple more here. The second thing is vocational recovery. Our national unemployment rate for people with mental health and substance use issues lingers between 82 to 85%. That is substantial. And those are people who then are doing nothing. They're sitting at home, and they don't have a steady income, or they're sitting at home on disability benefits. Yet we know that over 70% of people say that they want to work. And so one way that we can support recovery is actually helping people to identify and develop their meaning, their purpose, and their identity. And one way to do that is through employment. I'm not going to go into this because we're going to do a whole presentation just on employment, but you will have these slides to take a look at. Obviously, employment is related to much better quality of life and better outcomes around recovery. The next one that I'll do briefly is peer support. One of the things that we have found that substantially impacts wellness is this idea of other people who live in recovery providing supports to their peers. When people do not see recovery as a part of their life, they need to be surrounded with possibilities of recovery. There are a lot of trainings just on peer support. This is a poem that I would encourage you to read because it's a beautiful illustration of the impact that peers have on one another. Peer support is a professional discipline with training and certification and code of ethics. And just like any support or resource, it can be done well or it can be done poorly. We obviously want it to be done well. And these are some of the benefits, and you will see some outcomes related to peer support. These are some of the studies that go along with peer outcomes. And then the last couple, how do we promote recovery? Becoming trauma-informed. A lot of what we hear from people is that they are traumatized or re-traumatized through our behavioral health system that treats them more like a prisoner, or that they have done something wrong, or that something is wrong with them, rather than being sensitive around past traumas and how past traumas can lead to emotional distress, which leads to mental health diagnoses. So becoming trauma-informed is absolutely vital, both in our practitioners in the IDD field as well as the mental health and behavioral field. Okay, so I'm going to stop there. I'll find ways to sneak these other ones in as we go along. You're going to see a whole section on shared decision-making and information about medications and the collaborative approach that should be had with medications rather than a compliance-based approach. So definitely I would recommend that you go forward and look through all of this. I do want to highlight a couple of things in here, though. The first one is so important. The issue of medication is not about compliance or adherence. It's about effectiveness. And while we're trying to get people to become compliant with their medication, what we should actually be doing is exploring whether the medication is effective. And part of that medication is whether I feel it's effective for me or not. There are people that will choose voices over some of the side effects of medications any day of the year. Many people that would choose that. And so we need to have a different conversation around medication that's not about taking it, but it's about whether it works for you in positive ways. Okay, so all of that being said, we have a couple things. We have our next Lunch and Learn on July 1st. I think actually we have one in June, on the same Wednesday in June, that's just about trauma. So please tune in for that one. It's a very important webinar. July 1st, we're going to be doing wellness planning and recovery. August will be employment. And then September 2nd is personal outcome measures and how they're related to recovery. We also have our CQL Conference coming up in October in St. Louis. If you are going to be there, I will meet you there because I'm going to be doing, I think, at least 2 sessions during the conference. So I hope that I see you all there and I can meet you in person. So all of that being said, I know we started late, and yet I'm still 2 minutes early, but I just wanted to open it up for any questions or comments that people have.
Thank you so much, Cherene. That was amazing. I just love everything that you said about stigma and self-stigma and people feeling like they've lost their soul, and the stagnancy of the lives that we're providing through supports.
Yeah, you know, oftentimes we think of the issue as the diagnosis and the symptoms, but it really is not as much about that. People can learn how to live with symptoms. It's much harder to get over that internal dialogue that you have that you're incompetent and incapable and you know, all of those things that destroy your identity and your self-esteem.
So powerful.
Mm-hmm.
Well, we're opening this up to questions. So if anyone would like to put forward a question, please use the question box and just type in your comment, and I'll read that out for Cherene. We do have one, and this is from Patsy Cook. When you state that recovery is not formulaic, and she agrees, how does this mesh with the move in behavioral health care towards managed care?
Oh, that's such a great question. So I'm going to assume, tell me if I'm wrong, Patsy, that you're talking about things like service definitions and service populations and very rigid structures that are put in place around our system and the services that are offered. One of the things that I definitely advocate for is a different way of funding our services. If we fund them through service definitions and through fee-for-service, we really are limiting the level of flexibility that providers need to have when working with people and doing a lot of trial and error around what works and what doesn't work. One of the positive things, though, that I think has come out of the research are some of the evidence-based practices that give us some structures, if you will, that have some key ingredients around what could potentially be helpful, how this particular intervention has demonstrated effectiveness based on research. And so some of your evidence-based practices are going to have fidelity manuals and fidelity scales that go along with them. What they are designed to do is give you as a provider a lot of guidance around how to set up your system, your service, or your intervention based on what the research has demonstrated is impactful. So definitely when you're looking at some of your interventions in the work, look at the research based on it, look at your fidelity-based manuals. One of the things that managed care organizations are doing is looking at outcomes differently now. So they're looking more, they're starting to, let me give that caveat. They're starting to look at things like quality of life and recovery-based outcomes, fidelity scores, rather than that fee-for-service rigid service definition approach. And so we're going to start to see that happening around the country with managed care organizations that are looking for creative ways that provide alternatives to traditional systems. Some examples, if you go and look at Optum Health, for example, they are an MCO that funds a lot of research. They fund a lot of non-traditional services, and they find other ways to fund them that are more like capitated, performance-based contracts than fee-for-service. Last thing I'll say about this, because obviously I can go on and on about the managed care system, is MCOs also need to be educated about recovery and recognize that it is more financially feasible and has the greater outcomes when we work with people to advance their recovery and we are creative and individualized with them rather than focusing on a very stringent service or service definition. We, by the way, do a lot of trainings for MCOs. So if you're interested in having those conversations, we certainly can do that. Our organization has contracts with about 5 different MCOs right now. So it takes some work.
Thank you so much, Cherene. Well, that's all the questions that we have for the moment. I just want to thank you so much for Cherene's presentation, putting forward the voices of people who are involved in recovery and what makes a difference for them. And I think we can really see how this is for everyone. We focus on mental health services, but definitely for older people, for people who have intellectual developmental disabilities, physical disabilities, anyone in any walk of life can experience mental health, and it's really important that we realize and understand what makes a difference and what doesn't.
Absolutely.
Please feel free to contact Cherene if you have any other questions, if you're interested in learning more about this. She's a wonderful resource, and I just want to thank you so much for Cherene, just for speaking out on the behalf of people in recovery.
Absolutely. You're so welcome. And thank you all so much for sharing this time with me and being interested in the recovery of the folks that you support. And as Sarah said, please email me if you have specific questions, if you're looking for resources. We will make all of these slides available to you, and my contact information is on there. And then hopefully I'll be seeing you in St. Louis and seeing some of you in our next webinar.
Fantastic. And this recording will be posted on the website in a few days, and we'll email that link to everyone as well as a copy of these slides. Thank you very much, and I'm wishing everyone a great day. Thank you.
Thanks, everybody. Bye-bye.